Thank you, Tade. Yeah, we will do it slide by slide. So pleased to meet you all. So today we will talk about the Moonshot tools at hand. And as Tade mentioned, the ImmuneHealthXL program consists of 4 moonshots. So this is one of them. And this is really meant to be a supportive moonshot for all the other 3 moonshots. So the other moonshots are on understanding pathophysiology, developing improved treatments, and developing improved diagnostics and monitoring tools. And for all these moonshots, we envision that tools are critical to really make steps in improving all these aspects. So the long-term objective of this moonshot is to develop and apply more precise models of immunological processes in IMiDs, so that we can identify key disease regulators and that we can enable therapy development and diagnostic test development that both contribute to achieving drug-free remission. And then the next slide is from Rieke.
So yes, so we of course all know, us sitting here together, that IMiDs are driven by immunological disease activity. We are off balance in our immune system. And although we talk about cross-disease research and many different IMiDs, we envision that we will sometimes have common mechanisms underlying the immune disbalance between IMiDs. But we also think that mechanisms may vary between IMiDs, and even within one IMiD, we already know that some disease mechanisms differ between patients and even between different stages of disease. For instance, someone with IBD or arthritis, disease may be driven by TNF. Other diseases, IL-6 may be having a more important role. And of course, although all of us probably here today work to understand how immune balance and disbalance work, at the moment, we still are in need to get better precision models to understand disease pathogenesis between IMiDs, within IMiDs, and to also have models where we can test new drugs, new targets for therapy, to see whether in our models immune disbalance can be changed into a more balanced system. The value of our models here today is that we specifically look into a cross-IMiD approach. We would like to develop therapies that are selected for multiple IMiDs, tailored for multiple IMiDs. And we understand that sometimes we will have common disease mechanism underlying different IMiDs, and we can study that in our tool, with our tools and in our models. And sometimes we will have disease or even patient-specific mechanisms going on. And the eventual aim is that our tools will assist physicians and patients into application of personalized medicine, and of course, for all of us, into development of personal medicine. Next slide.
So the commonality in the approach is to create a unified IMiD process model strategy. And there's quite a lot of different model types and quite a lot of different tools that you can use to analyze the readouts of these models. And there's a lot of different diseases, different IMiDs and subtypes. So it's really the strategy for how to develop these models and how to test these models and to bring them further to higher TRL stages that is unified. And that is something that we also would like to harmonize. So one aspect of the approach is that we want to develop current models that have already been developed or are starting to be developed, that we develop those towards implementation across IMiDs, so that they're not only studied for one disease, but that they're also studied for similar mechanisms in other IMiDs. Because of the complexity of all these different components, we think there will be a stepwise process in which we can improve current model components, and these could vary from many different aspects, culture conditions, to readouts, to bioinformatic analyses. It will be necessary to develop novel analytical techniques to get more precision into the biological processes that are occurring in the models, and we aim to be able to model more complex processes, such as different tissues that in which processes interact with each other, or more complex processes like chronicity of certain responses, or responses in which multiple cell types interact with each other in a spatial temporal fashion. And part of this approach will then also be to integrate various models into more complex systems. Finally, this is more the longest part of this approach. The aim will be to personalize models across IMiDs, for models to be able to capture more variability of mechanisms, so that they can be really tailored to specific patient subsets, and in the end towards individual patients.
So now, what does it really mean for us in our moonshots for the next 15 years? All of us, all the stakeholders together, we talked about this at length. And of course, there is a patient need, that there is disease heterogeneity, and sometimes that complicates diagnosis and challenges the acute prediction of treatment. Now, in tools at hand, specifically, we want to have our models that we have nationwide going to be in place to be used to test different drugs, different therapies, and also to elucidate better what is going on in specific IMiDs or cross IMiDs and in specific patients. And our standing point is that all over the country, we and the stakeholders all together, we have different models of immunological interactions between cells or molecules. These are mostly in vitro models, and these models we are all using sometimes in splendid isolation to test what is going on with the immune mechanisms, and how can we find targets to modify it, or how can we test drugs into that. The first stage, what we will do is we will bring together what we know is present in the Netherlands in terms of models, and start to collaborate more strongly together as a whole consortium to bring these models to the next steps of development. And you can envision that between now and 2030, we will have identified, and already we have partly, the immunological in vitro models that can be used to study the IMiD underlying mechanisms, and also to interfere with that with novel drug or existing drugs. And that may start coming from a relatively simple, straightforward models that we have in the lab, having either a few molecules or one cell type. By 2035, we will make this next step, all of us together in ImmuneHealthXL, in that we start to integrate the more direct minimalistic models into larger models, where we cannot look at just one drug and one target in one cell, but where we can look at different cell types together, and more complex models to study mechanisms of disease and modulation thereof. Also, these models will have material from healthy donors, but also material from that are directly patient derived. And that brings us to our moonshot at 2040. We aim to have precise disease progress models that predict the effects of immune modulation in each individual. So you can hear that we progress from models that are already existing into strongly collaborating, integrating these models, building more complex models at different sites in the Netherlands towards very patient-specific models using biopsy materials and studying patient-specific cell or molecule behavior using assays. Next slide.
Yeah, so an important aspect of these milestones is to cut up the process into different steps where we can use these milestones to bring focus and prioritization towards specific projects that we will select based on these aims in the milestones, and also to engage the necessary stakeholders, because we're really aware that already from an early phase we will need to engage all the relevant stakeholders, and it varies from innovative companies to larger commercial parties, regulatory authorities, patient organizations, and funders. So these stakeholders will all be engaged in these processes dependent on the stage where we are. And we already envision that for the moonshot of 2030, that we will work with some of the models that we currently have identified to getting these towards adoption by pharma and biotech. So already the relatively straightforward, maybe a bit more reductionistic models need to be, at least one of them, we aim to be adopted by pharma for drug development. And we also feel it is in this first phase really important to benchmark the findings in the models to other data sets that really show the truthfulness of the models, that they really truly capture biological processes that occur in patients with IMiDs. And we aim to improve the current model components and readouts. Then for 2035, when we aim to model more complex processes, we again think it's really important to combine models and readouts and to perform this benchmarking, but also then for these more complex models to strive towards adoption of pharma by these more complex models, and ideally also at least one model that will be adopted in clinical care. So we think that it also has a priority that a more complex model shows robustness and validity that is high enough for use in clinical care. And that is really, I think, an important focus for prioritization. In 2040, when we aim even higher, there we want to model variable processes and variability in immune responses between individuals. There we think it is really important to have larger companies on track with their own research and development pipelines that contributes to the further development and use of these models in the wider pharma world and in clinical care, so that we can really go for a wider adoption of such models in the clinical care use by multiple patient subgroups, so that we can really transform our healthcare. And there we also think that engagement of patient organizations will be critical to get certain tests or assays that are derived from these models reimbursed by the regulators. So as an example of models that are currently or recently been developed, this is a study in which we performed, you can see it as a kind of a benchmarking exercise for the models. We did a multi-omic analysis of patients with two different IMiDs, systemic sclerosis and Sjögren's syndrome, where we performed a multi-omic analysis of multiple tissues of these patients, lymph nodes, affected tissues, and blood. And we focused on understanding the regulation of T cells in these patients. You can show the next slide. and found that in these multi-omic data sets that these T cells and the NK cells in the affected tissues and lymph nodes were enriched, and that these expressed CD7. Can you show the next slide?
Right, yeah.
Yeah, and then we built these in vitro models, where in one model we modeled the autoreactive response in these patients with co-culture of different adaptive immune cells. And in the second model, we modeled the attack of the immune cells of the affected stromal cells for systemic sclerosis. And we used these models to test the blockade of CD7, and we found that both these responses were dependent on CD7. And we also tested CD7 positive cell depletive antibody, a candidate treatment, and that was also effective in these models. And just for one detail is that the tissue attack model was a 3D organoid-like model with a collagen matrix in which patient fibroblasts were seeded and co-cultured with PBMCs. And the readout was the contraction of these collagen hydroplugs by the fibroblast. We could prevent that by treatment with these anti-CD7 compounds. And finally, then the last slide, we used this knowledge to treat one patient with systemic sclerosis with the CD7 depletive treatment. And there we could show that in affected skin, CD7 positive T cells and NK cells were depleted, while regulatory T cells and other cells remained intact. And we had preliminary observation of clinical efficacy in this patient.
If you look at the next slide, there's another example, and excuse me for using our own examples. Of course, when we look at T cell dependent B cell differentiation, we know that that underlies formation of high affinity class switch antibodies that are so often detrimental in IMiDs. And of course, in the real world, this all sets into action into secondary lymphoid organs, often lymph nodes. And ideally, if you want to study actions of drugs or study mechanisms of, in this case, B cell differentiation, ideally, of course, you want to go to a situation that is as close as real life. And currently what we do is we use animal models. And although we think animal models are very valuable, we also specifically here in ImmuneHealthXL want to add human in vitro models to this testing toolbox. And if you think of the models that can be used for this, on one hand, you can use very minimalistic models where, for instance, you only use B cells and you give them artificially the signals that you know are needed to make B cells differentiate into antibody secreting cells. And then you can manipulate the system by adding in drugs that, for instance, inhibit NF-kappa B, or for instance, that target certain molecules on differentiating B cells. If you want to go to a bit more complex system and not only study a B cell, but also want to understand what is happening with the T cell in your system, as these processes are T cell driven, then we have B and T cell interaction models, where we add in cognate antigen, and then the B cell differentiation and T cell differentiation is driven by this antigen and by the MHC class II antigen and T cell receptor interactions. It's driven by the interactions between these T and B cells that modulate one another. And also here you can study different targets, different drugs, and now not only study what is happening in the B cell, but also what is happening in the T cell and how your drugs affect the interactions and the communications between different cell types. Then to mostly mimic your, of course, 3D situation in lymph nodes, you want to go to a 3D model. And in the Netherlands, many groups are currently developing 3D models where you put in B and T cells, but also stromal cells, follicular reticular cells, follicular dendritic cells by themselves. And now look in this very complex 3D mechanism, how are the mechanisms that underlie B cell differentiation into memory formation or antibody secreting cells, and how can you manipulate these combined interactions to either stop memory formation or antibody secreting cell formation. There is already established for a 3D B cell lymph node structure working group in the Netherlands, and that is obviously also part of ImmuneHealthXL. How ready are these systems for the clinic? Rogier just showed you a very, very good example. I can say that in our lab, for instance, this system has been used by pharma to test some of their novel drug candidates to be used hopefully in future to target specific IMiDs. So this is just an example of the different models.
Yeah, I think this slide is already a bit part of the discussion. So we have multiple grant opportunities that are coming along, in which we invite the community to interact and collaborate and to submit. Most specifically, this program call, which is when awarded, will be an opportunity for projects. So what we in our initial thoughts are thinking of as possible projects are when you think again about focusing and about priority, and that it should be models that improve current models that benefit from running projects. You can discuss about it, but it seems kind of logical, at least to prioritize cross-image modeling opportunities, because we really feel that this is a critical component of speeding up all these processes and projects that focus on harmonizing across sites or across techniques. Of course, it's of interest to study disease processes that are of interest of participating SMEs or large companies. But we invite you all for discussion on this.
Yes, thank you, Rogier